I'll go ahead and introduce Alan. The welcome comes from both David and I. We are so thrilled that you're here joining us today at Transforming Veteran Oral Health, and in particular for this session, expanding the role of rural health clinics and veteran oral health care delivery. Our speaker today is Mr. Alan Morgan. Recognized as among the top 100 most influential people in healthcare by Modern Healthcare magazine, Alan Morgan serves as the Chief Executive Officer for the National Rural Health Association and on the Board of Directors for AIDPH. He has more than 31 years experience in health policy at the state and federal level, and is one of the nation's leading experts on rural health policy. Mr. Morgan served as a contributing author for the publications Policy and Politics in Nursing and Healthcare, the Handbook of Rural Aging, and for the publication Rural Populations and Health. In addition, his policy articles have been published in the American Journal of Clinical Medicine, the Journal of Rural Health, the Journal of Cardiovascular Management, the Journal of Pacing and Clinical Electrophysiology, Cardiac Electrophysiology Review, and in Laboratory Medicine. Thank you so much, Alan, for being here. We're pleased and privileged to receive a presentation from you today.
Great, Annalise, thank you so much. Appreciate that introductory remark. And from what you might have gathered from that brief bio, at the National Rural Health Association, we cover the waterfront of healthcare in a rural setting. Everything from long-term care, behavioral health, skilled nursing, hospital, various settings. And I have to open with a couple disclaimers. First, these are the three topics that I'm talking about that I am most passionate about: rural health, veterans, and oral health. Those of you that are in this session now that know me know that all too well. That being said, it is going to focus specifically on oral health, rural, and veterans, which is very targeted, this presentation. But this is going to be, believe it or not, an overview of where these three topics intersect. And even though they're very, very well defined, the complexity of these three issues together can become mind-numbing incredibly quick. So this is the first disclaimer. I'm going to provide an overview of the opportunities and challenges in dealing with these three combined topics, number one. Number two, if I do my job correctly afterwards, you're going to say our health system or my particular a facility has to get involved in this. And I've done my job, that's what you're going to say. And at that point, that is where you need to contact either the State Office of Rural Health or the State Primary Care Association. These two entities can help you directly link with the VA to contract for the program that I'm going to be talking about. And so I'm not going to get into the weeds of the mechanics of contracting with the VA to provide increased services, really just talk about, again, the opportunity that it presents. Now, for the final disclaimer or takeaway, and this is really important because I recognize not everyone is engaged in rural health like I am, so this is important. The topic of this is expanding the role of rural health clinics. But if you read the white paper, which I'm sure everyone has, it really talks also about the opportunity for federally qualified health centers. So in a rural context, you have rural federally qualified health centers, number one, you have rural health clinics, number two, and then you have rural hospitals, number three. All three of these provider types really need to think about contracting with the VA for expanding services. The report talks about how FQHCs as a program, and they are a federal program to expand access to care to underserved populations, are uniquely qualified for collaborating with the VA because they have a history of integrating services. But if you just attended the last new model session, breakout session, you recognize that rural health clinics and hospitals now over the last 5 years have really been engaged in new payment models that are pushing them into this comprehensive care model approach. So they too are relevant and important partners of the VA in expanding services. But just from the beginning onset of this, rural health clinics are a federal payment type. They usually are primary care points of access, usually a doc, a PA, a nurse practitioner, and more often than not in rural, they are for-profit entities because they're small, but they are providing care to underserved populations. Whereas rural federally qualified health centers are a program designed to provide care to underserved populations. They can be in both rural and urban. And I think what we find is these different provider types, when they're functioning in a small rural community, and particularly addressing the unmet needs of rural veterans, you see that their mission remains the same. And so it's relevant to all. So with those brief disclaimers to start with this, let's really start with what's the focus of this discussion. And that is the 2018 Mission Act, where the VA expanded care to veterans through this community care network, which actually serves as a contract vehicle for the VA to contract with providers outside the VA healthcare system. I think a little bit of history is important here. Historically, the VA and the nation's various veteran associations have not been inclined to contract with providers outside the VA. And from a policy standpoint, this makes sense. You want to keep the resources and the funding internal to the VA so you have a strong VA program. That being said, it's just been a recognition that there just simply have not been the access points in rural and frontier communities for these veterans. Not having the access points creates a significant barrier to care, and it leads to even more egregious healthcare disparities faced by rural veterans. So the 2018 Mission Act was a recognition of we're just not meeting the needs of these rural veterans. We have to have a mechanism by which we can contract with rural providers to provide this care where the veterans live, which is a fabulous opportunity. And again, what I highlighted earlier is this expansion is really particularly helpful given the innovative model of care integration that rural federally qualified health centers have been positioned to deliver during the history of the program. But also, and I take this right from the white paper, also it's important to note the rural health clinics and rural hospitals with their emerging model of care now too are also equally qualified to participate in this program. More information on this is included in the white paper. I know you've heard this referenced several times before. It's just such a spectacular document that covers oral health for veterans nationwide. And I'm really proud that it has a specific focus on rural communities within this white paper as well too. So just a little bit of background on this, and I think this is important to understand the context of what we're facing when it comes to rural veterans. 20 million veterans live in the US, and about 5 million of those veterans, which really ends up representing 24%, live in areas that are designated as rural by the US Census Bureau. Okay, so do a little bit of context here. This is important. So 20 million veterans representing 24% of the US population. Outside of the veterans, roughly 20% of the US population resides in rural America. So you're seeing 4% increase of veterans per population versus just overall. That highlights the increased prevalence of veterans in rural communities. So let's be honest, 4% across the US, that is a significant number of people. And so just under half live in the South, and then the other large component of them live in the Midwest, which probably isn't surprising if you look at rural populations. They tend to go through the Southeast, down to Texas, and up through the Midwest, although obviously rural is everywhere in the United States. It's unique in everywhere, but that's where you see the greatest prevalence of rural veterans. 44.6% have a high school diploma, 35% have some college, and 12% have a bachelor's degree. 39% served during the Vietnam era, 31% have a disability. and 18.4% have a service-related disability. And this, just keep this in mind as I get towards the end of the presentation when we talk about qualifications for VA care, because that's going to come, again, really important into this discussion. Taking that down one step, just looking at the rural veteran demographics then, you're seeing what represents 4.7 million rural and highly rural veterans. Highly rural, that's what we call frontier in the policy sense of it. But only 2.8 million are enrolled in the VA. Now, when you look at that, that's 58% of rural veterans, which is actually significantly higher than the 37% enrolled in urban areas. So the good news is a higher percent of these veterans are enrolled in a rural context. 18% of those rural enrolled veterans have at least one service-connected condition. 6% are women, 15% are minorities, 52% earn less than $35,000. 27% do not have access to internet at home. Let me make a particular point about this. When it comes to behavioral health, substance abuse, those are two issues in a rural context. As we see the greatest utilization of telehealth services. The VA is known as a national leader in telehealth care. So right there, that presents a tremendous opportunity and current barrier to care. With only 27%, with 27% not having access at home, that's almost 30% that you're not going to be able to utilize telehealth service. So it necessitates, again, a local point of access to care. All right, so now that's the big, large picture. Let's focus a little bit more into the oral health component of this. And you have heard similar stats in the breakout sessions that just prior to this, but rural veterans, well, 62% are less likely to have a dental visit compared to urban veterans. And among veterans, rural residents are more likely to have all their teeth missing than urban residents. And the relevance of that, most notably in a rural context, is that oral health has a direct impact on the ability for veterans to obtain employment and keep employment. It's not just a health issue, but it's also an economic issue for these rural veterans. That being said, one thing that was highlighted by the white paper, and I can't stress enough, I almost shared with you the entire gambit of rural health data that we have when it comes to rural veterans and oral health. The fact is that the data available cut in a rural context is just unacceptably lacking. It's one of the reasons why a decade ago, we pushed for the creation of a Office of Rural Health within the Department of Veterans Affairs. We had to have that point within the VA that would help promote not just programs, but the necessary research as well. That problem still exists today. It's just impossible to promote prudent public policy and change practice without access to relevant data specifically highlighting rural veterans, their needs for oral health, and how those are successfully addressed in a rural context. That VA Office of Rural Health is innovated that I mentioned just a second ago, has implemented several initiatives to not only support the needs of veterans living in rural areas, but also to help train providers to support rural health. And again, these approaches are specifically highlighted and directed to include non-traditional stakeholders, clergy, social workers, disability advocates, all into the healthcare process. And I got to tell you, if you have worked in an FQHC, you get this, because this really is fundamental since the very creation of the FQHC program to have this integrated approach. Hence why it seems to be a real no-brainer to integrate oral health services within rural community health centers and be able to partner directly with the VA. Again, as I mentioned, that movement is moved beyond the walls of FQHCs into rural health clinics and rural hospitals now as well too. Well, let's talk a little bit about the key rural oral health challenges. This should look familiar to everyone on this call because they are the same oral health challenges that we face regardless of whether you're in a rural or urban setting. In a rural setting, however, these challenges just are exacerbated. And certainly because the impact of COVID has made the workforce situation even more dire. What makes rural unique is the distance to care or lack of access to care. High rates of substance abuse, much greater in a rural context, and low rates of dental care utilization, significantly more in a rural area. I believe, though, that the opportunities are highlighted within the oral health policy topics when we're looking at that. The ability to innovate in a rural context and these policy topics of increasing Medicaid coverage and expansion and providing an oral health coverage benefit under Medicare, where you have a higher percentage of seniors in these rural communities, so very important. But there are other particular issues. And again, these are not focused solely on oral health, but they actually, they are actually in this component, they are focused on oral health, but they bleed out into all aspects of rural healthcare as we talk about it. Okay, so that I've taken this kind of from approach in this presentation. I wanted to, at the very beginning of this, cover really focused in on oral, veterans, and rural. So let me back out just a tiny bit for a few slides to talk about the overall rural landscape, because it's just so very relevant to the need of what we're talking about during this session. And I use this particular slide, I've used it before because it does the best job of encapsulating the story of rural. And you've got this picture of the father and his daughter looking out in the sunrise. It just really, it is what we expect rural to be. It's every hallmark story. And they're looking out in the distance and they see workforce shortages, vulnerable populations, and chronic poverty. And that's an accurate portrayal of both the challenges and the opportunity that we face in a rural context. When you look at innovations in healthcare policy, they all are happening at the rural level, where these intense pressures are forcing this innovation to occur, which I have to be honest with you, I think that is really relevant when we're talking about oral health and the integration of oral health into primary care. When you're looking at these significant workforce challenges, the ability to integrate oral health into primary care and bring veterans and their care directly into these local access points has the potential of really stabilizing and expanding care going ahead. All right, so this is important. I'm not representing the VA or the governments, the federal government. So I can acknowledge an issue that hopefully everyone understands all too well. One of the challenges is just the availability of providers to deliver this care. And let us be honest, and right now, because of COVID, you have increased utilization in these community health centers, rural health clinics, and hospitals. And because a lot of patients put off care, just the volumes of patients, most notably in community health centers right now, are at all-time record levels. Finding that availability, we need to expand as many points of access as we can just to meet the need, because currently these clinicians are overworked as is. And when you look at the totality of veterans that could participate in this, it's important to note of the entire veteran population, there's a significant number that are not eligible for VA benefits because they're not service related. There's another component that there are other qualifying factors, but the veterans are not aware they're eligible, so that knocks a lot off. And then among those rural populations, there's a significant number that simply can't travel to the VA, which knocks it off even more. So of the entire universe of veterans, we're really only treating this sliver. And if we are successful in getting the entire veteran population to seek care, there are not going to be enough providers, and certainly when it comes to oral health. I can acknowledge this as a reality, but still, the goal should be to expand these points, access of points of care in rural to as broad as we can to help address as many veterans' understanding of the significant limitations that we currently face in workforce. So I just want to lay that out on the table as a recognition of the problem when it comes to workforce and oral health care in a rural setting. Now, the challenges facing rural health safety net pre-COVID have only become greater as the time has gone on. And we're all aware of this, but the impacts on the populations have been significant and dramatic. Rural has an older, sicker, and poorer population. I think you see a lot of this holding true among rural veteran populations as well, too. So knowing that population that's being served in rural, this is something I alluded to at the beginning of this presentation. I just like this slide because it really lays out what we're talking about in numbers. And of the 1,400 total federally qualified community health centers, 42% are located in rural areas. Now that number roughly equates to about 500 rural federally qualified health centers, 500. So knowing that 500, you go down one line and you see you have 4,500 rural health clinics. So again, back to the point, even though FQHCs have historically uniquely been positioned to treat veterans under this new program, just the sheer volume of these rural health clinics out there make them a necessary partner going ahead. Rural hospitals, whether they be rural prospective payment hospitals, these are the larger hospitals that tend to have anywhere from 50 to 300 beds, or the roughly 1,300 critical access hospitals. These are facilities with 25 or fewer beds. Almost all of these facilities will own a rural health clinic. And so those rural health clinics are called provider-based clinics. And again, it's important to note just the breadth of these access points out there, especially when you talk about the fact that only 9% of clinicians practice in a rural setting. And that happens in an area where 77% of the rural counties are designated as primary care HPSAs. And that's before you even talk about the complete lack of access to specialty care when it comes in a rural context. That's relevant, all of this, when you look at a map. And this is a map of the US showing the prevalence of Medicare patients with 6 or more chronic conditions, just to highlight that elevator speech that rural America is older, sicker, poorer. This is the sicker part of it. It really indicates that fact. And if you overlay this map with a map of the National Rural Health Association's membership, it's unfortunately just a mirror image. The reason why you don't see a lot of this out in the mountain states and upper Midwest is simply because a lot of that, let's be honest, they're federally owned land. People don't live in that. They're national parks. You just don't have that population. But those are the areas when we refer to significantly rural, or the federal designation term of frontier rural is what those connotate. So there's 2 things that come to play here, especially with the rural veterans. I think anytime you talk about rural and health inequities, health disparities, you think of populations' geographic health inequities from rural, right? You have geographic health inequities because of the distance to providers, because of lack of providers. But I don't think what gets enough attention, that there are also population-based health inequities in a rural context. And in fact, rural is where you see this combination of rural geographic equities meeting up with veterans who have health disparities as well too, inequities, and population health inequities, whether they be African Americans, Hispanic, Latino, Asian, Pacific Americans, all living in rural communities. These all just further compound the issue and necessitate the opportunity to have additional access points as a result of that. So this slide, I like it because it highlights everything that I've shared with you so far. This upper line shows populations as they present themselves to rural hospitals. And you see in a rural patient hospital base, the percentage of elderly, veterans, those patients experiencing poverty, diabetes presenting in a rural hospital, and premature deaths as well too. And looking at that, then you go down to the bottom of the slide and you really see at hand the access issue, where you get the primary care clinician, dental health, and mental health provider lack of access. It's just incredibly dramatic, the disparities meeting the lack of access in this particular point. And this particular slide that I pulled together just really highlights that veteran and dental component. Great, tremendous need, a tremendous lack of access when it comes, and it comes together in one. A lot of this is just the general lack of health insurance and the impact that it has in rural communities. And I think at least when we're talking with policy leaders and they talk of lack of health insurance, they're really focused, as they should be, what does that mean to the population at hand? But in a rural context, it also has a direct relation on the financial viability of these provider types. And the lack of health insurance is driving hospital closures, rural hospital closures. And when you lose those access points, you also lose access points to veterans. And unfortunately, rural emergency rooms oftentimes are utilized for that entry point for oral health care problems once they present themselves severe enough. Uninsured patients showing up at hospital emergency rooms with severe oral health care needs as a result of that. And not just what it's done in the past, when we look at what it's looking forward as we move forward, you just see, more than 450 rural hospitals are at risk for closure and at risk for losing those access points. To me, there is no greater need for this collaboration between the VA and these rural access points, not just to deliver healthcare to the populations that need, but also to make sure we're shoring up this safety net. And it is a safety net in a rural context of preserving access to care. It's tough to highlight, I run through these data, and every time I do, I hope you're seeing the same thing I do. It's just shocking the significance in the disparities faced and the challenges faced. But as I mentioned earlier, it also highlights a great opportunity. And that's the reason why, just trying to pull all this information together, our organization is embarked on a rural health initiative, rural health oral initiative. And so what we do is we pull together all the data, everything I've said so far, and all the resources into one particular website to make sure it's really easy. Why I think that's important for all of us that are listening on the call is when you're talking to your peers locally within your health system, or you're talking at the state, regional, or national level, it's really important to have a shared understanding of the challenges at bear and the opportunities that we're seeing. And that's one of the things we want to make sure that we're highlighting. Okay, as I'm trying to stay on time and bring us to a close here, I want to highlight this. To be able to qualify for VA dental benefits, veterans must meet at least one of the following criteria. And I'm not going to read through all these, but it's a good indication of the complexity of this, of just knowing whether you're qualified. If you are in a rural hospital, rural health clinic, or rural community health center, you don't have to worry about this. As it's been communicated to me from the VA Office of Rural Health, once you've contracted with the VA for this and you're in the system, how this is intended to work is the veteran will show up, they will present their card, you'll be able to contact the VA, they will quickly assess the eligibility and let you know immediately then whether that particular patient can qualify within this VA program, or how it would be working if you haven't had the contracting. You have to determine whether they have to pay out of pocket, whether this is uncompensated care, or whether this is some other mechanism by how are you going to be able to finance the care that you're going to be providing to this particular individual. But again, it's this partnership that this program puts in place to allow the VA to determine the eligibility, to be able to very quickly, hopefully, work that out. I say this, so you know, the program's been up and running for several years now. And at the beginning of this, as you might expect, it was there were some glitches in this that was reported from our particular members. Two things I heard. The members, obviously, the reimbursement rates from the VA are not the same that you would have in a private sector. So there's a lower reimbursement rate. So there's that issue. But at least there is reimbursement, number one. Number two, at the beginning, there was some delay and some glitches in the communication between the VA and the provider of eligibility. I have not heard those particular glitches from our membership in quite some time. So it is my understanding that they've all been worked out and that this now is an efficient process going ahead on this. So let me wrap up this, because I always feel like when you're giving some sort of talk this, you have to give examples of how this is successfully working. And I particularly chose two examples that from our members in federally qualified health centers and what they're doing with their veterans in their community. And I picked these two to, again, bring it right around to the very beginning of my presentation, where I said, you know, even though it is noted that FQHCs are uniquely positioned for this, when you look at these two good examples, these can be done in every single rural health clinic or rural hospital as well too. And it gets to the heart of the value of this opportunity for expanded care. And that is to break out of the walls of your facility, engage in a community setting to provide enhanced quality of care for the rural veterans. It's been noted by the Institute of Medicine through their landmark report on quality in a rural context that rural providers are more inclined to collaborate across provider type and outside of the healthcare system to ensure access and quality care for their residents of their community. And I really believe that this new opportunity to partner with the VA for these rural points of care outside the VA setting just brings it all together to address healthcare disparities for veterans in the area of oral health, while actually delivering the care that we've all been striving for the last 20 years, that we can finally hopefully recognize and serve as a model that can be replicated in urban areas as well too. So really appreciate the opportunity to present on this. I'm delighted that I actually stayed remarkably on track for that. As much as I want to talk more, Annalise, I'm going to pause right now and we'll take questions from the group.
So exciting. This was an awesome presentation. I have like 50 million questions and that was so wonderful. And I have so many notes taken and lots of follow-up, but I'll allow attendees who have put questions in the chat to signal for those for answers first. And number one, we have, why is it that providers and veterans are not familiar with the VA DIP program that is underwritten by MetLife and Delta Dental? So maybe you could touch on that a little bit and maybe, why that might be an underutilized resource.
Yeah, that's almost a rhetorical question. I asked the same thing myself. Why is that? And unfortunately, I have to believe, I want to go back to what I said earlier about the totality of veterans and the fact that there's a lot of them that are not eligible and there's a lot of because of distance, but you cannot shortchange the lack of knowledge as a barrier to care and the information sharing. And that is probably one of the most frustrating things that I think our organization deals with, because it seems like it's the easiest obstacle or barrier to care to overcome. It doesn't require any more funding. It's just getting the word out, making this opportunity known. So I don't have the answer to that, other than I think it comes down to communication. And that's not the only example of it, but in a rural context, having rural providers be able to know this. And that's exactly why we're at conferences like this right now, because it seems like such an easy thing for all of us to share.
I could not agree more. Another question in the chat is, have rural hospitals or rural health centers considered affiliating with dental support organizations, especially those that accept Medicaid patients?
So the easy answer is I have heard examples of that over the years. I have heard examples of that. I think it's a best practice among rural hospitals, rural health clinics, and rural community health centers to affiliate with larger educational organizations within the state. And you see that across the healthcare spectrum. It has happened. I am optimistic and hopeful we'll see greater utilization of that going ahead. I think, and I mentioned this early on, that my organization represents more than 90% of the nation's rural hospitals, rural health clinics, rural community health centers. They all have their unique issues, but oral health care is the one thing that unites everyone together. And there's just been a tremendous amount of passion and movement on this going ahead. So I remain optimistic about it. It does happen. There are models of it out there, and it's something we need to promote going ahead.
I wrote down some questions about non-traditional stakeholders, which is kind of what you're alluding to here, and opportunities for collaboration. But before I get to that, I wanted to point out, because I loved the graphic that you showed. Well, I didn't love it. I thought it was a very wonderful visualization of some unfortunate information, and that, where rural hospitals are closing and where the highest risks are. And some of the darkest states actually have the highest concentration of veterans. So Texas is one of them, and Florida was another. Texas, California, and Florida have the highest concentration of veterans in their population. So looking at how those closures are occurring, and then thinking about the existing disparities, and on top of that, the broadband issue that you brought up earlier. So 30% of veterans don't have access to high-speed internet that can really kind of maybe remedy if a closure occurred or they're at risk for that. Where are the opportunities to absorb some of that? Are there opportunities to, and what would be your call to action around that?
Annalise, I cannot thank you enough for that question, because you allowed me to realize, I forgot one of my most important points that I didn't make on that. And that is one of the reasons why I do share that hospital map. And we're not talking particularly about hospitals today, but one reason why I share it is not because of that. It's because it dispels a myth. And the myth among rural health is that it's a population issue. What are you going to do? Rural people, the people are moving away from rural America. People are getting older. People are dying. What are you going to do? If that was the case, then where you would see all of these problems with oral health, obesity, veterans' access to care would be in Western North Dakota, South Dakota, Western Nebraska, Western Kansas. That is the part of the country that is depopulating. But over the last 20 years, I think there's only been 2 rural hospitals close in that area. They're not closing because the people that are there are farmers and ranchers who actually do have access to health insurance. All these health disparities are happening in areas that still have high populations of rural, but extremely high populations of uninsured. They don't have a primary care physician, so they don't seek care in a timely manner. They can't afford preventative medicine. They cannot seek and have dental visits on a regular basis. And all of that, it's the bill coming to be paid as a result of that. In a rural context, the issue that's driving this is uninsured and health disparities. How do we deal with the reimbursement component of it? And that just comes right back to really the focus. What I hope the takeaway of this is yet another opportunity to partner with a federal entity to not only increase the access to care, but also keep the doors open on these access points.
Yeah, that's a great point. And it actually kind of segues into another question I had, which is around policy implications, and really highlighting that, yes, there are federal policy implications. There are probably different policies or support systems on the local, state level. And I'm wondering if you could kind of talk about how we need to activate around policy or other solutions that you see in private and federal and independent sectors. It seems like there's a lot of room for everybody to be a stakeholder in a solution here.
I just got into a long-winded discussion about this. We had our big conference last week, and I actually got into the discussion talking about this very issue. At the federal level, Medicare, Medicaid, two big payers. That is really the federal role for it. I would argue there is another federal role, which is scope of practice and licensure. It has to be addressed at the state level, I know, but the inconsistency on it is problematic. You had referenced earlier, and I didn't address, and that is the broadband access. More than $700 million invested into broadband expansion, the largest in our nation's history last year. We're now in the process of trying to roll that out. I have heard just such amazing stories of teledentistry during the pandemic. And in full disclosure, we just didn't hear those success stories prior to the pandemic. And that integration of primary care into oral health care and the potential for it is huge going ahead. And that really is a federal level as well too. But I mention that because you get licensure, telehealth regulations, those really are at a state level. Local level is the focus of this session right now, Annalise, and it is what can you do at a local level to partner up with the VA? And hopefully it's that first call to the VA or to the state office of rural health or state primary care association, say, look, I need to be doing this at our facility, or our system is not doing this, or I know a system that hasn't engaged in these yet. Again, that communication of how do we link this up?
That's wonderful. So I hope everybody has some takeaway points for today, and I hope people feel activated to engage with their local and state opportunities for supporting veterans at the rural veterans at the state and local level. And Alan has already presented his contact information, so if you see an opportunity for follow-up, please do that. And you know what? Thank you so much, Alan. I loved your presentation, loved your comments, and we really appreciate everything that you're doing for rural veterans.
Thank you, everyone. Really appreciate the opportunity to be here. Thank you, Annalise.
Of course. So I'm going to read out the CEU code for this session. Please write it down as a reminder. Everyone who is requesting CEU should have their code at the evaluation presented at the very end of the conference. And this session's code is rural. And Alan and I like to pronounce that the same way, where it is similar to rule instead of rural. But that is spelled RURAL, rural 215 vet